All right, let's examine the concept of organ transplant and what it entails, who needs it, what's going to happen to the patient. All right, this is still in the same concept of immunity. Now, let's review how our body works, our immune system. So, our immune system recognizes self from non-self based on something called HLA. So human leukocyte antigen is a protein found on every cell in our body. So as long as the protein signature is the same, so as our white blood cells circulate in the bloodstream in the capillaries, so they bump into cells as they circulate, and each time they make contact with a cell, so they recognize the protein signature, the HLA, the self, and then once they find, let's say, a bacterium, a virus, a fungus, or even a cancer cell, so when they encounter these, then they discover, oh, that wasn't the same HLA, that was different. So the immune system is activated, and then we start attacking the foreign cell, right? So that's how it works. So here, how can we do this for kidney transplants or any transplant for that matter? Now, if let's say me and Felicia, I'm the recipient, so I need a kidney, and then Felicia is going to give me her kidneys. How do I make it work since her HLA is different from my HLA? So how does kidney or any organ transplant work then? Since it's, unless you have an identical twin, identical twins have the same HLA, but everybody else have no identical twin. So how do we make transplant possible?
Because with blood.
Immunosuppression. All right, so we have to settle with anything close enough for the graft or the transplanted organ to survive. We will have to suppress the patient's immune system to prevent it from attacking and killing that organ. Make sense? All right. So I won't test you on the whole transplant process. We're not really involved in that. So the laboratory people do that. So they take a blood sample of the donor and the host, match first of all, it should be matching blood type, same blood type, and then blood type is the same, and then we'll start matching whether or not the HLAs are close enough. And they do all sorts of other procedures. And then finally, when they say, okay, it's a good match, and then we'll plan the transplant procedure. Now, when do we begin the immunosuppression? Before, during, or after the transplant?
Before.
All right, so we begin before, continue it during the surgery, and then forever after the surgery. Right, that's the only way this will work. Unlike several decades before, wherein we took out the diseased kidney, meaning let's say my kidneys no longer work. Say I have lupus, right? And lupus destroyed my kidney. It's not like my kidney is diseased, okay? It's just not working anymore. So I have end-stage kidney disease. It's no longer working. It's still there, but it's not working anymore. So there's really no need to remove it, okay? It's alive, okay? My kidneys are alive. They're just not working. So it's less risky leaving them there rather than removing them, because the renal arteries are so large, the renal veins are and arteries are so large that there's a high risk for bleeding if the surgeon will remove them. So we'll leave them alone. Instead, where will they put the donor kidneys or the graft? they'll put them in the iliac fossa, which is a pocket inside your pelvis. If there's a picture, all right, here's the picture. Okay, so here's your old kidneys. Hey, these kidneys don't work anymore. So instead of putting them there and using the renal arteries to attach it to the donor kidney, they won't do that. They'll just put it here, and then they'll use the iliac arteries, which are considerably smaller compared to the renal, and then they'll use that for an anastomostat. So they'll connect the renal artery and vein to the donor kidney. All right, and then that should work. And then the ureters will be attached to the bladder, and then there we go. We have a recycled kidney. All right, so you mentioned that, yes, the patient has to be immunosuppressed because we don't want any rejection, right? So next thing is we're going to talk about rejection now, because there are other complications like infection, for instance, but the most serious concern with transplant is the rejection, because again, this donor kidney here is not the same, has a different HLA than the rest of this patient's body. So we have to be careful in preparation, and then especially after the surgery. So we have to make sure we immunosuppress the patient enough. We don't want to do it too much either, because now the patient's at risk for infections. So we just want to do it enough. We target specific cells in the immune system that are involved in organ rejection, meaning not all of the immune system cells are involved in organ rejection. So we've only identified a few dozen immune system cells that are involved in organ rejection. So those are the cells that we want to suppress, right? So we'll be giving the patient medications that are cell specific so as to only immunosuppress the patient enough to prevent organ rejection. Any questions so far? All right. Back to medical management. Okay. So we discussed I mentioned the tissue typing, blood typing, antibody screening, and then HLA matching. All right. Okay. Knowing that this patient will be taking immunosuppressants, let's look at first this patient's life. So I am the patient. So what was happening to me before the transplant? What was my life like? We'll use the kidney as an example. So what was I doing? My kidneys were not working. I'm waiting for a donor. So what was I doing while waiting? It could be months, years, decades.
Dialysis.
I was on dialysis, probably peritoneal or hemodialysis, right? So either way, my life was not easy. Okay. And then finally the day came, they gave me the news. Oh, you got a donor, you got a matching donor. Yippee. All right. And then we underwent surgery, and then and now this is the first post-op day. Okay, I finished the surgery, and now I'm looking forward to a dialysis-free life. I won't have to be tied. I had plans. Okay, I'm gonna travel. I had all these planned already. All right, and now comes a bummer. Now the patient will have. I could potentially have one of three or more. Okay, it's not really limited to one type of rejection. I could experience all three. Now again, this chapter, this is what, chapter 48. This is only talking about kidney transplantation. However, the mechanism of transplant rejection and prevention or management of the rejection is the same. Okay, now this will not be mentioned in other chapters. Let's say in in, let's say, liver transplant, heart transplant, this will not be mentioned anymore. They're all mentioned here. Now, like I said, the management will be the same and the nature of the transplant will be the same. But will the manifestations of transplant rejection be the same? Say a kidney rejection, is that the same signs and symptoms as a liver or heart rejection?
No.
Okay, very good. So the manifestations will be different, of course, because this is a different organ, right? So the guideline, of course, the common sense would be if an organ is being rejected, what will be signs and symptoms? Will it be signs and symptoms of that organ failing or another organ failing? I mean, if I experience kidney rejection, will I have manifestations of liver failure?
No.
Yeah. No, Professor.
The kidneys are being destroyed. They're the ones that the kidney is being rejected. So what manifestations will I have? Liver
Kidney-
failure or
Kidney
kidney?
failure.
Okay.
Liver,
Signs.
kidney failure.
Right. So it'll be specific to the organ, signs and symptoms wise of rejection. It'll be specific to the what organ was transplanted and what organ was being rejected. Make sense? Right. So let's now discuss the three types of rejection. Let's differentiate them on using three factors. So we'll try to answer, when does the rejection occur? Number two question is, what happened exactly? How did this rejection happen? What really went wrong? And then the third, what can be done about it? All right, let's repeat. So what are the three possible questions on the exam for each type of rejection?
What happened? What can be done about it? And
When the rejection started?
Whatever.
All right, start with the time first. Okay, so when does it happen? When did it happen? And then the mechanism, which is how did it happen? And then the third is what can be done about it. All right, so these are the three questions on every type of rejection. Again, this could be on a kidney rejection, transplant rejection, liver transplant rejection, heart transplant rejection, or lung tissue or lung organ transplant rejection. All right, so let's start with the first one. Hyperacute rejection is the most rare of all three. It's extremely rare. It's this rare. So I listened to a symposium of one of the kidney transplant surgeons at Shands Hospital in Florida. He was probably in his 40s, late 40s when he spoke. And he said he only saw, and he's been practicing since he was in his early 30s. And he's only seen one hyperacute rejection episode. Right? It's that rare. Okay? Now, he does transplant surgeries all the time, but then he only saw one hyperacute episode of rejection in his career. So that's how rare hyperacute is, because that's the period. Let's answer the time. So when does it occur? Within 24. Actually, it could be beyond 24. It could also be up to 48 hours. But basically, it's within 1 to 2 days of the surgery, right? It may
Do you know
have.
the details about that case?
Sorry.
Do you know the details about that case when he finally saw it?
Yeah, we'll discuss what happens, right? So why is it so rare? Because did we just do the surgery like this? Like, oh, okay, let's do surgery right now. Did we do that? Did we do the transplant like that? Is it planned that quickly?
No.
Not really, right? I mean, we did tissue sampling, we did tissue matching, right? Cross matching. before we did the surgery. So did we do our homework? Did we do our diligence that everything matches before we did the surgery?
Yeah.
Yes, we did our due diligence. So therefore, is there likely a mistake when we do a surgery procedure, a transplant procedure? Is there likely a mistake when multiple people, okay, so the surgical team, the laboratory team, okay, they did their jobs. Is there likely going to be a mistake?
No, it's
No.
very planned out.
Very rare, okay? So that's why this is so rare, because everybody did their job. However, this is just a freak event wherein something still happened, like nature took its course. Remember, this patient and the donor had different HLAs. They have foreign, so each other cell is foreign to the other. So here we can just say that this is just a freak of nature. Okay, so somehow it's unfortunate that the recipient, the host, rejected the organ. All right. So what the nature here is, there's clotting that happens. So as soon as they did the anastomosis, anastomosis is when you connect an organ or a blood vessel. Okay. So as soon as they anastomose the artery in the vein, and then they removed the clamps, and now blood started flowing. So the blood from the host or the recipient started flowing into the graft. It triggered a clotting cascade. Now the clotting cascade is widespread throughout the organ, throughout that transplanted kidney. So if this is the kidney, for instance, right, so this is the kidney. As soon as blood enters it, it triggered a clotting. Now every capillary and blood vessel, any other blood vessel inside the graft is now filled with clots. Now how do you fix that? It's filled with clots. It's overrun. It's completely filled with clots. Every single capillary. Can you fix it? Every capillary, every artery, every vein is filled with clots. Can it be fixed?
No.
Nothing can be done. So
No.
if it happens, then all we can do is, I mean, is this organ still okay? I mean, can we use it?
Nope.
No, not if
No.
it's filled with clots. So it's not red anymore. It's not pink. So it's gonna turn black. Right? It's gonna turn gray and then black because it's filled with clots. So what's the only thing to do?
Remove it.
Remove it. Surgery was not successful. We had a hyperacute rejection. I don't know what you do with it. Put it on the grill, do whatever with it. Okay, it's useless. Okay, so we can't leave it in the the host body. So we'll just take it out, close the patient back up, and then bring them the bad news. Right? So that's all we can do. So when does it occur? Within 24 to 48 hours. And then what exactly happened to it?
Widespread clotting
Okay,
throughout the kidneys.
the graft was filled with clots. Okay, somehow a clotting cascade was triggered. The graft was filled with clots, and then now what can we do? Nothing. Take it out and bring out the bad news. Any question on hyperacute? Again, don't worry, this is extremely rare. All right, it doesn't happen all the time. Let's go to the second one. The acute rejection is the most common type of organ rejection. It occurs within 3 to 14 days. However, this is not limited to one episode though. So it's not limited to the first 3 to 14 days. It will occur again and again. Okay. Now, why? What happens in acute rejection? In acute rejection, this is caused by cytotoxic activity of the host immune system. Because what is the job of the immune system? What is it supposed to do?
Fight against infections.
Okay, fight anything foreign, correct?
Mhm.
Is this graft eventually gonna be accepted as hey, will the immune system say, hey, you know what? You've been here a while. We're friends now. You're one of us. Okay, homie? We're friends now, homie. We're not gonna kill you anymore. Will that ever happen?
No.
No, because the immune system knows one thing. That graft there, that kidney that you put there, has a different HLA. Doesn't look like us. Okay, it looks different. We're gonna kill that. Okay, so despite our best efforts of giving the patient immunosuppressive therapy, we gave them medications every day, round the clock, okay, every 7 days a week, 365 a year. The immune system found a way to still target the graft, okay, because it's lifelong mission. That is a foreign organ. That's not my organ. Okay, I'm gonna destroy that. Okay, it knows one thing. So this is what happens in acute rejection. So it's really caused by lymphocytic cytotoxic activity. So the lymphocytes found a way to still target the organ and try to destroy it. Now, what can be done about it? So you know the nature. So what can be done if despite our current dosing of immunosuppressive therapy, the immune system found a way to still fight it and try to destroy the transplanted kidney. So what do you think can be done about it? Any ideas? What would you do? I'm taking these drugs, these doses, and then my immune system still found a way to fight. So what will you do?
Well, if you raise the dose.
Okay, very good. So we will either raise the dose or add more immunosuppressive drugs. Okay, so that's how it's managed. So let's review acute. So when does it occur?
Three days after?
Okay, is there a limit?
No, but up to
Okay, so
start with 3 days.
yeah, so starts from 3 days. So that's why I said hyperacute is within 24 to 48 hours because acute starts around third day. But it's not limited to one episode. This may happen again and again and again throughout this patient's life. All right. So as long as this organ stays viable inside that host body, they will undergo multiple episodes of acute rejection. But what do we do every time it happens, Kurt?
Up the dose.
Okay, we will up the dose of the immunosuppressants. We will even add more, okay, every time it happens. Any question on acute rejection? All right, last type is chronic rejection. Now, unlike acute, because when we say acute, what is the onset of symptoms? Is it sudden or slow?
Sudden.
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 So it's easier to detect signs of acute rejection because the manifestations occur like this. Like within hours, within minutes, we see the signs and symptoms. So what will be likely the manifestations of acute kidney transplant rejection? Acute kidney injury or chronic kidney disease?
Acute kidney injury.
Acute kidney injury. So can we detect acute kidney injury?
Yes. Absolutely, yeah.
Yes, absolutely.
Yes.
What about chronic kidney disease? Do you see that in real time?
No, it's
It takes time to notice it.
Correct.
It's gonna take
Chronic
time.
kidney disease did not occur overnight. It occurred over several months, several years. By the time we found out, it's already advanced, correct? So that's the nature of chronic kidney transplant rejection. So it's not as easy to detect as AKI. AKI, which is the manifestations of acute kidney injury, acute organ transplant rejection. It's quick, it's fast. However, in chronic kidney transplant rejection, it's so slow that we don't notice it right away. And then by the time we do, it's usually advanced already, meaning the nature of the rejection is chronic inflammation, meaning slowly the lymphocytes killed, because there's chronic inflammation. So little by little, parts and cells of the, so many nephrons die every few days, every few months, and then until the organ is, filled with just scar tissue, right? So that's the nature of chronic kidney rejection. So what can be done about it? How did we manage CKD? Can we avoid anything harmful to the kidneys?
NSAIDs.
Correct. Yeah, including NSAIDs or antibiotics, right? Can we also increase the immunosuppressive therapy because this is caused by chronic inflammation? Can we do that?
Yes.
Yes, that can also be possible. But since this is chronic, so is there really full success here in stopping it? Is it really possible to fully stop it, like acute rejection?
No.
No. However, can we delay it?
Yes.
Yes. So that's the only management. So let's review chronic rejection. So this is after, besides years, you can also say after many months. Okay, so after many months to years. And what happened again? So this caused by chronic inflammation. So little by little, the organ is destroyed. And then what can be done about it is you can increase the immunosuppressive therapy. You can do conservative treatment, preserve what's remaining of the organ, avoid anything nephrotoxic, take care of the kidneys. Don't let any more harm come to it. But eventually the patient will lose that kidney again. Okay, because that's the nature of CKD. Right, so that's it. That's the, if you can read the entire section, the entire paragraph, that's the story of hyperacute, acute, and chronic rejection. So this chapter 48 this section is only talking about kidney transplant rejection. However, the nature will be the same. Okay, so when we go to the next chapter, let's say under liver transplant, it'll say the same. Hyperacute liver transplant rejection, acute liver transplant rejection, chronic liver transplant rejection. Same, but what will be different? Will the signs and symptoms be the same?
No, they'll be different.
No.
Very good. So here, the manifestations you see here are specific to a kidney transplant rejection. Make sense? But the nature and therefore the treatment or management will be exactly the same. Okay, so we'll use the same immunosuppressive drugs. Only difference again are the manifestations. So here are your drugs. Again, these are drugs that are specific, cell-specific. Let's say this. Look at the first two. So tacrolimus and cyclosporin are both called calcineurin inhibitors. So calcineurin inhibitors target lymphocytes. Okay, so here they target T lymphocytes. All right. So they target specific cells, not like steroids, wherein steroids will inhibit everything. Okay, so these two both target lymphocytes, and these are the sad consequences. So it is nephrotoxic. Therefore, they cause hyperkalemia because once you destroy kidneys, then potassium rises, right? And here are your teachings for the patient, okay, on how to take it. And here's a different drug. So this is a mTOR inhibitor. This one, mycophenolate anti-proliferative. When we say anti-proliferative, these usually target the bone marrow. So that's why you'll see here it affects not only the bone marrow, but all rapidly dividing cells, just like these cells in the bone marrow. So the GI tract is lined with a single layer epithelium, which are rapidly dividing. Okay, our mucous membrane are those types of cells. They rapidly divide. That's why we don't have a mouth ulcer that lasts for more than a week. That's why our injuries in the mouth heal so fast, because our GI tract cells are rapidly dividing. All right. That starts from our lips all the way to the anus. Right, so these are the drugs. There are only how many listed here? 1, 2, 3, 4, 5. Okay, only 5. No, 6. But again, they're similar. So if they're the same, like here, these two, sirolimus and everolimus, are the same. So therefore, they should have the same nursing implications. All right. Any questions on the drug therapy? Okay, please take notice of the paragraphs. Okay, so let's say this one, these are details related to the drugs in the table. Okay, so grapefruit and grapefruit juice interact. So that's one of the key.
Is that an exam question?
Most probably, yeah. And then these are the
Thank you.
other side effects as well. All right. So not just the table. Table, I can grab questions here, but there are also some details in the paragraphs. All right. Very good. Select all the applied questions here. Any questions on organ transplant? Okay, take another short break. I'll send you